our next speaker, Dr. Satyam Arora, who is an additional professor, Department of Transfusion Medicine, Postgraduate Institute of Child Health, Noida, UP. To adding towards sir's profile, sir is a certified advanced biotherapy professional. He also holds a degree of MD Transfusion Medicine, and he's also an observer to Center of Cell and Gene Therapy, USA. To talk about sir's awards and accolades, sir is a recipient of Narendra Award from ISBT 2022, Young Scientist Award by ISTM, that is 2021, and Dr. Harlot Gunshon Fellowship from Mexico 2012. Over to you, sir, for your insightful deliberation.
Thank you. Thank you for a nice intro. I hope I am audible and my slides are visible.
Yes, sir.
Okay, thank you. Before I begin, I would like to thank Kaho for this great initiative and Dr. Gajendra and Dr. Shami for giving me an opportunity to talk about adverse event and transfusion services. And I think the speakers before me made it very clear that why do we need to have quality, and the whole main purpose is to avoid any adverse event in a whole chain of transfusion services, right from the donor to the patient. So I will be briefly discussing the journey of hemovigilance as well through my presentation. So this is how I have outlined my presentation. I'll just briefly touch the transfusion chain, hemovigilance, both in recipient and in donor. Then what is the National Hemovigilance Program of India, and what has been the Indian experience and what has been the Indian data. So we know that this is the whole transfusion chain. We collect these blood units or apheresis units from a donor, which gets processed, which reaches to our clinical site or the hospital, and then finally gets transfused to our patient. And to study any adverse event in this whole chain, there was a concept introduced called hemovigilance, which is a set of surveillance procedure from the collection of blood and its components to follow up with the recipient to collect and assess information on unexpected or undesirable effects resulting from therapeutic use of this labile blood product. So this was a major concept which was introduced many years back internationally, and in 2012, in our country through the National Institute of Biological, this national program was enrolled in December 2012. So what does hemovigilance do? So if you see on your left, we access data, we collect some baseline information, both from the donor sides and from the recipient side. That data is collected as per the SOP. It is analyzed. There is some result that comes out from this data, which designs a further intervention. This intervention is implemented. And again, we see whether that has improved our transfusion chain or not. So this concept is very important, and this is derived from the industry, from the pharmaceutical industry, and has been implemented in the transfusion cycle. So it has major three parts. One is the recipient, which checks for the transfusion reactions, which can be an acute or a delayed. Then there is a product processing component, which talks about, the product processing, labeling, quality management of that. And there can be errors and near miss events during that part. And then finally, our main source of blood, that is donor. So we want to study that collection of blood from these donors is safe. And that even the infectious markers screening and surveillance is done as part of the donor hemovigilance. So coming to this chain back again, and I'll be starting from the most important part, that is our recipient. So a recipient transfusion reaction is also called as adverse transfusion reactions, which is referred as undesirable, unintended, adverse response to administration of blood and blood components or derivatives throughout the period. And, we need to relate that it is due to blood. The overall reports range from 0.5 to 3% from various sources. And the main attempt or the main aim is to recognize them early and stop transfusion if there is a reaction. Before we initiate a transfusion reaction, there is an importance of having consent, and the patient should be explained that what is the risks and benefits, as well as what are the alternatives that the patient has when the transfusion is to be offered. Broadly, these reactions are classified as infectious and non-infectious, and non-infectious are further classified as acute and delayed, which are further classified as immunological and non-immunological. Coming to hazards of transfusion, TTI, that is transfusion-transmitted infections, have dominated the blood safety, and now they are relatively rare in the developed country, but they're still a major threat in the developing and underdeveloped countries. They're majorly by the viral infections, bacterial or protozoal infections. Before we move ahead, we should understand that which infection, there There are a lot of infections that get reported every year. We had a COVID pandemic very recently. So which agent can be classified as a TTID, that is transfusion transmitted infectious agent, so that it has to be present in one of the blood components that we collect. It should have a asymptomatic subacute infection in this donor. That should be a protected infectious period in the donor, and the same microbial nucleic acid could reactivate or initiate the same infection in the recipient. So if there is an agent which classifies or which has all these four characteristics, is classified as TTI. So there is a battery of organisms which have been proven to be transmitted through blood, but as per our government initiative and guidelines, we are testing for only 5, which are 3 viral, HIV, Hep B, Hep C, 1 bacterial, that is trypanosoma, and then 1 protozoal, that is Plasmodium. So these are the minimum mandatory testing that we are offering to our blood services. When we talk about picking up a transfusion reaction, we have to think about 4 basic vital signs that we should know before we are initiating a transfusion. And if there is any change, we can really suspect a transfusion reaction. So there are temperature, pulse, blood pressure, oxygen saturation, respiratory rate, and fluid balance. There are some very important red signs which I feel every physician who's offering a blood transfusion should know about. That if as soon as you initiate a transfusion, if there is a back pain, loin pain, hemoglobinuria, new vomiting or nausea, chest pain, shortness of breath, angioedema, rise of temperature, rigor, hypoxemia. So if there is any change of vital, it indicates towards a transfusion reaction and should be monitored and reported. In case of an anesthetized patient, a new finding of hypoxemia, hypotension, shock, hypertension, hemoglobinuria, and DIC can be a sign of blood transfusion. As soon as the blood transfusion, blood reaction is suspected, one should stop the transfusion. It should check the component for any bacterial contamination, that is change of color or rise of bubbles. They should assess the change in vitals, cardiovascular status, urticaria, angioedema, treat the acute symptom, consult the hospital transfusion services, and send out the labs which are required. So this is a very good, template of how a transfusion reaction should be worked up and reported, which is by the National Hemovigilance Program of India, which gives us a step-by-step guideline at what all we need to do to, diagnose and to report a transfusion reaction. So when we pick up a transfusion reaction, we have to keep note of symptoms, pre and post vitals. We have to check for hemolysis, send back the bag and the sample to check for ABO gripping. We even do DCT testing, visual inspection of the bag. Another sample from the patient's separate IV line is sent for bacterial culture to see if there has been a bacterial introduction in the bloodline. Urine, some more samples for, investigating the hemolysis, and a chest X-ray can also be sent to classify this transfusion reaction. So very broadly, I'll just go back again as the acute transfusion reactions. If they are immune mediated, they can be acute transfusion reaction, hemolytic reaction, febrile non-hemolytic reactions, severe allergic and anaphylactic reactions, allergic reaction with IgA deficiency, TRALI, that is transfusion-related acute lung injury. So all these are acute immune-mediated. The non-immune mediated acute are TACO, which is the transfusion-associated circulatory overload, and a hypotensive reaction, as well as an hypothermia, which can be due to a rapid infusion. Coming to delayed, that is after 24 hours of transfusion, is a delayed hemolytic transfusion reaction, transfusion-associated graft versus host disease, post-transfusion purpura, and non-immune mediated delayed is the iron load, which is commonly seen with our thalassaemic patients. So this is a big list of all transfusion, non-infectious transfusion reactions that can occur. I will not be going into the detail, but just briefly covering the other part on this. Coming to the next part, which is the donor. So that is called as the donor hemovigilance, or the safety of donor in our transfusion scene. So this is basically systemic surveillance of blood collected from donors and aim to secure and improve the donor safety. And this is basically reported from AABB to be at 20.8, 20 donors in 1,000 donors who are donating in US, with most common being the vasovagal, followed by hematoma. As per the Indian data of the Indian National Hemovigilance Program, we are reporting very low at around 2 per 1,000 blood donors that are reporting to the national data, and I'll be touching that point at the end of my slides today. So the aim of donor vigilance is to improve donor safety and satisfaction, to analyze the risk factors, implement and evaluate preventive measures, provide evidence-based support to blood donation, reduce the frequency of adverse events, and finally, we all want that there should be an increased donation frequency. So this is a big list of characterizations of donor reactions provided by ISBT and IHN. They're classified as local, generalized, related to apheresis, allergic, and some serious cardiac events as well. So they're further classified if the blood is outside the vessel, if there is pain, injury to any major vessel. As far as apheresis is concerned, there are citrate-related reactions. Hemolysis during procedure rarely can even cause air embolism and an inability to return blood if there is a reaction to a donor. Coming to imputability. So this is, I think, equally important point when we are establishing the cause of a reaction either in a recipient or an adverse event in a donor, that whether donation of blood or transfusion of blood is causing this adverse event. So when we have a conclusive evidence, we give an imputability of definite, giving a score of 10 by 10. When we have a clearly in favor, we give probable. When evidence is intermediate, we give it possible. When there is no other reason, we give unlikely. And when we know that the blood is not cause of this adverse event, we give it excluded. So this is very important for us to understand whenever we are establishing a cause of certain event or a reaction after blood transfusion or even blood donation, that it was because of blood. Now, briefly just covering the National Hemovigilance Program of India. As discussed, this was launched in December 2012 by the National Coordinating Center as NIB in Noida. And they even started a web software to report. And this was launched in the recipient part of this program was launched in December 12, and the donor part was launched in June 2015. And it's the organizational structure is there's a blood center which reports to the NIB as the coordinating center, and they make a report out of it, which sends out to the government and CDSCO to make policy. The silent features of the national program is that they are non-punitive. So we don't identify who has reported. There is confidentiality which is there. This is independent. So NIB is neither a report, regulator, or is it somebody who can take punitive actions against you. There is a team of experts which sits on this data and analyze and sees that what kind of evidence are we able to make from this data. We want credible analysis of our own data. This is system oriented and responsive. So as milestone, So as milestone in 2012 we had, and then 15 we had the donor, and then there were a lot of international lineages which was made by this program. So this was a software which was made, and we used to report to it, and the data goes to the NIC server. These are the templates of the forms which are there to report our donor reaction or recipient reaction. There are a lot of data which has come out from the national program and which has gave our own data to support the national policies. Just to briefly see, the recipient data has classified that one of the most common reactions are FNHTR and allergic, and we need to introduce leukoreduction as one of the most common measure to reduce the incidence of FNHTR. Even donor vigilance data showed that younger age group first-time donors had more reactions. Most common was localized, and they were reported within 30 minutes of donation. So that's the reason we should monitor all our donors for at least 30 minutes. So these were some further documents which were released by the national program based on the data which was collected. There's a concept of hemovigilance nurse, which was introduced by many centers across the country. Just looking at the international part of it, so SHOTS is the one of the most famous and the older hemovigilance program in UK. And one of the recent data coming out of SHOTS showed that there were more common near miss events. So this shows that once your blood transfusion system is matured, they are not only picking the reaction, they're also picking the processes. And they were able to pick almost 1100 near miss events in their data. Even they are reporting death, and they are analyzing. And one of the most common cause of death were TACO according to the data by SHOTS. Just briefly walking through what our data has been. So this is the 5-year data of our national hemovigilance program. There have been many centers which are reporting, and most common reaction was FNHTR, which was followed. Even a lot of TACO and allergic reactions were reported. The outcome is usually resolved in these patients. The denominator data, we had very high data that is being reported to the donor side, and we see 19 lakh reported, and after validation we had only 16 lakh donor reports, and the reactions which were reported were around 4,000. And the most common reaction which was reported by the National Donor Hemovigilance Program was the generalized, followed by local and others which were wrongly classified. And our national data reported that there were 2.45 donor reaction on per 1,000 donations in our country. So this is just a brief comparison of donor reactions which are reported across our country, and we see the national data is coming at the lowest. One of the reason is the above data has been the prospective studies, and this has been the national study with very low reporting, and we still need to enroll many centers for it. Finally, to conclude, identification of adverse donor reaction is a part of a long-term objective of managing and reducing the occurrence of donor reactions. Documentation, reporting, analysis, and comparison with the peers of adverse donor reaction is an essence for donor hemovigilance, and implementation of strategies to prevent donor reaction should be an ongoing and dynamic process. Thank you.
Wow, that has to be called as a great learning. Thank you so much, sir, for your insightful deliberation.